and welcome back to iHealthConnections. I'm your host, Dr. Rashmi Nair. I'll be presenting Medicaid and information that you need to be aware about Medicaid. The original program began with Medicare, which included Part A hospital insurance and Part B, which was medical insurance. Today, these two parts are called Original Medicare. In 1972, Medicare was expanded to cover the disabled people with ESRD, which is end-stage renal disease, and people who are 65 or older. At first, Medicaid gave medical insurance to people who got cash assistance. Now the program has extended and expanded to a larger group. There is a story behind Medicare and Medicaid law. President Johnson wanted to recognize President Truman, who in 1945 had become the first president to propose national health insurance and initiatives. On July 30, 1965, when President Lyndon Johnson signed the Social Security Act Amendments 18 and 19, popularly known as Medicare and Medicaid law. The bill signing ceremony took place at the Truman Library in Independence, Missouri. Former President Harry Truman was enrolled as Medicare first beneficiary and received the first Medicare card. Thus, Medicaid health insurance program for elderly Americans became the law. For 50 years, these programs have been protecting the health and well-being of millions of American families, saving lives and improving the economic security of our nation. Medicare and Medicaid started as basic insurance programs for Americans who did not have health insurance. They have changed over the years to provide more and more Americans with access to quality and affordable health care they need. So what is Medicaid? Title 19 of the Social Security Act and a large body of federal regulations govern and define federal Medicaid requirements, state options, and authorities. The Centers for Medicare and Medicaid Services, or CMS, within the Department of Health and Human Services, is responsible for implementing Medicaid. Medicaid is a joint federal and state program together with the Children's Health Insurance Program, or CHIP. Medicaid provides coverage to over 72.5 million Americans, which includes low-income adults, children, pregnant women, elderly adults, and even individuals with disabilities. For states participating in Medicaid program, federal law requires states to cover certain groups of individuals that include mandatory eligibility groups. Some examples are low-income families, or qualified pregnant women and children, and individuals who receive Social Security supplementary income. The Affordable Care Act established a new methodology for determining the income eligibility for Medicaid, now which is based on Modified Adjusted Gross Income, which is also referred to as MAGI. MAGI, or Modified Adjusted Gross Income, is used to determine the financial eligibility for Medicaid, CHIP, and premium tax credits and cost-sharing reductions available through the health insurance marketplace. By using one set of income counting rules and a single application across the programs, the Affordable Care Act made it easier for people to apply and enroll in the appropriate program. This methodology considers taxable income and tax filing relationships to determine financial eligibility for Medicaid. Medicaid agency determines the eligibility groups that do not require income eligibility exemption. The coverage may be based on enrollment in another program, such as the SSI or the Breast and Cervical Cancer Treatment and Prevention Program, or some individuals who are exempt based on blindness, disability, or even that they are 65 and older. Coverage is effective either on the date of application or the first day of the month of application. Benefits also vary retroactively for up to 3 months prior to the month of application, if the individual would have been eligible during that period that they had applied. Coverage generally stops at the end of the month in which the person is no longer meeting the requirements that deem them eligible. Medicaid also has a medically needy criteria. States have the option to establish a medically needy program for individuals with significant health needs whose income is too high to otherwise qualify for Medicaid under the other eligibility groups. Medically needy individuals can still become eligible by spending down the amount of income that is above a state's medically needy income standard. Individuals spend down by incurring expenses for their medical and remedial care for which they do not have health insurance. Once an individual's incurred expenses exceed the difference between the individual's income and the state's medically needy income level, which is also referred to as the spent down amount, the person then becomes eligible for Medicaid. The Medicaid program then pays the cost of services that exceeds the expenses the individual had to incur to become eligible. Individuals must also meet certain non-financial eligibility criteria. Medicaid beneficiaries generally must be residents of the state in which they are receiving Medicaid. They must be either citizens of the United States or be lawful permanent residents. In addition, some eligibility groups are even limited by age or by pregnancy or parenting status. Let's review some Medicaid facts. Medicaid is a national public health insurance program which is offered for low-income people. 1 in 5 Americans are covered by Medicaid, many of those who require complex and costly care. Majority of Medicaid enrollees lack access to affordable health insurance. Medicaid finances nearly a fifth of all personal health care spending in the US, providing significant financing for hospitals, community health centers, physicians, nursing homes, and even jobs in the healthcare sector. Medicaid is subject to a lot of federal standards. States administer Medicaid programs and have flexibility to determine covered populations or covered services, even the healthcare delivery models and the methods for paying physicians and hospitals. It's a federal-state partnership. States can obtain a Section 1115 waiver to test and implement approaches that differ from what is required by a federal statute. Because of this flexibility, there is significant variation across state Medicaid programs. Under the original 1965 Medicaid law, Medicaid eligibility was tied to cash assistance as part of their aid to families with dependent children or federal supplemental security income, which started in 1972. States could opt to provide coverage at income levels above cash assistance. Over time, Congress expanded federal minimum requirements and provided new coverage options for children, pregnant women, and people with disabilities. Congress also required Medicaid to help pay for premiums and cost sharing for low-income Medicare beneficiaries and allowed states to offer an option to buy in to Medicaid for working individuals with disabilities. Other coverage milestones included severing the link between Medicaid eligibility and welfare in 1996 and enacting the Children's Health Insurance Program or CHIP in 1997 to cover low-income children above the cutoff for the Medicaid program with an enhanced federal match rate. Following these policy changes, for the first time, states conducted outreach campaigns and simplified enrollment procedures to enroll eligible children in both Medicaid and CHIP. Expansions in Medicaid coverage of children marked the beginning of later reforms that recast Medicaid as an income-based health coverage program. In 2010, as part of a broader health coverage initiative, The Affordable Care Act or ACA expanded Medicaid to non-elderly adults with income up to 138% FPL, which is $17,236 for an individual in 2019, with an enhanced federal matching fund. In addition to covering the services required by federal Medicaid law, many states elect to cover optional services such as prescription drugs, physical therapy, eyeglasses, and dental care. Coverage for Medicaid expansion include preventive services and expanded mental health and substance use treatment services. Medicaid also provides a comprehensive benefits for children, known as Early Periodic Screening, Diagnosis and Treatment services. Medicaid covers a broad range of health and long-term care services. Unlike commercial health insurance and Medicare, Medicaid's long-term care services include both nursing home care and many home and community-based long-term services and supports. More than half of all Medicaid spending for long-term care is for services provided in the home or community that enable seniors and people with disabilities to live independently rather than in institutions. Given that Medicaid and CHIP enrollees have limited ability to pay out-of-pocket cost due to their modest incomes, federal rules prohibit states from charging premiums in Medicaid for certain beneficiaries. They also prohibit or limit cost sharing for some population and services and limit total out-of-pocket cost to no more than 5% of family income. Over 2/3 of Medicaid beneficiaries are enrolled in private managed care plans that contract with states to provide comprehensive services, and others receive their care in the fee-for-service system. Managed care plans are responsible for ensuring access to Medicaid services through their networks of providers and are at financial risk for their cost. In the past, states limited managed care to children and families, but they are increasingly expanding managed care to individuals with complex needs. Most states are engaged in a variety of delivery system and payment reforms to control cost and improve quality, including implementation of patient-centered medical homes, better integration of physical and behavioral health care, and development of value-based purchasing approaches that tie Medicaid provider payments to health outcomes and other performance metrics. Community health centers are a key source of primary care and safety net hospitals, including public hospitals and academic medical centers, provide a lot of emergency and inpatient hospital care for Medicaid enrollees. A large body of research shows that Medicaid beneficiaries have far better access to care than the uninsured and indicates that Medicaid eligibility during childhood is associated with reduced teen mortality, improved long-run educational attainment, reduced disability, and lower rates of hospitalization and emergency department visits in later life. Rates of access to care and satisfaction with care among Medicaid enrollees are comparable to rates for people with private insurance. Medicaid coverage of low-income pregnant women and children has contributed to dramatic declines in infant and child mortality in the United States. Research findings show that state Medicaid expansions to adults are associated with increased access to care, improved self-reported health, and reduced mortality among adults. Gaps in access to certain providers, especially psychiatrists, some specialists, and dentists, are ongoing challenges in Medicaid and often in the health system more broadly due to overall provider shortages and geographic maldistribution of healthcare providers. In summary, Medicaid is a joint healthcare program administered by states and the federal government that provides coverage to over 73 million Americans, which is roughly 20% of the US population. Eligibility standards for Medicaid vary by state, but federal law requires coverage for certain populations, including qualified pregnant women and children, low-income families, newborns, and others who meet the eligibility guidelines. Since the passage of the Affordable Care Act, states may choose to expand Medicaid coverage to people with incomes up to 138% of the federal poverty level. 31 states and DC have chosen to expand the program. 1 out of 3 children in the US receives coverage through Medicaid or the Children's Health Insurance Program, CHIP. Some people who receive Medicaid benefits are eligible for both Medicaid and Medicare. They are referred to as dual eligibles. Medicaid covers more than 60% of all nursing home residents and 40% of costs for long-term care services and supports. More than half of the Medicaid program is managed by third-party companies to deliver more comprehensive care and save money for the states. Managed care has proven successful not only for delivering more comprehensive care to beneficiaries, but also saving money for the states. Because states can determine the design of their own Medicaid programs, they have many opportunities to test innovative payment and service delivery models that reduce inpatient hospital admissions, enhance care and monitoring, and create better care in many other ways. Medicaid benefits are divided into 2 categories: federally mandated benefits and optional benefits that the states may choose to incorporate. Prescription drug coverage is determined by states, but all states cover outpatient medicines for patients. Please subscribe to my podcast for similar topics or more on Medicare and Medicaid. Thank you.